So I've been asked multiple times by various fellows of mine to go over the OCTs because some of the places they do not get enough exposure to the OCT. So I came across this really nice Abbott images and cards. So I'm going to use them to illustrate some of the OCT images. And you can think it as a quiz. So if I ask you, what are you seeing here? So, describe what you're seeing. You can practice with me and see what you come up with. So what are you seeing in this image? So the first thing that you notice here is this, there is a wire. So this is the wire. This is the catheter. And then you're noticing that there are some stent struts, right? These are stent struts. And right next to it, there is, because it's inside of it, this is called atherosclerosis. Atherosclerosis. And you can see there's some calcium that is developed. So calcium shows up as a circumscribed lesion here. Sometimes it does have some shadow, but if it's thin, you will not see the shadow. And if you look at this thing, this is a side branch most likely. So that's how it's showing up. So you have atherosclerosis. You have some calcific atherosclerosis. So calcium can develop inside of the stent, and then you have a side branch. So what would you do with this? Now, if this is an MI, you can put a new second stent in it. Just want to mention that this atherosclerosis has a lot of fluid in it, water. So when you balloon inside of the stent, sometimes it squishes out. But when you leave it, it comes back. So you have to do something about it. You can do atherosclerosis if it is very thick. If it is at least, and this is what I use, really no studies, but if it's up to 0.5 millimeter thick, I would use laser, okay? And the laser, what it helps is it's kind of melts it and breaks it down. It makes a vapor and can actually ablate it here. And you can see it on the OCT if you do before and after. And it helps you to better expand the stent if you do the laser. My way to choose the laser is that I use whatever the size of the stent is divided by 2 as the laser size. So 6 French can take 1.4 and 0.9 millimeter lasers. Okay, it's called ALCA catheters. And then 7 French can take 1.7. So many times I end up using 1.4 millimeter laser in these cases. All right, let's go to the next case. What is this? And I'm going to give you some time to ponder upon this and think about, what is this? Again, you see a vessel, okay? You can see the EEL somewhere here. Okay, this is external elastic lamina. You can see the intima, which is very bright. Okay, this is fibrotic. And then you can see this, there's quite a bit of shadow here. Okay, so most of the time, this is what red thrombus looks like, or a plaque rupture. So you cannot really 100% tell, is it red thrombus or plaque rupture? How will you know? By the clinical presentation. So if it is a plaque rupture, you will have shadowing behind it. Why red thrombus? It is a subacute thrombus, I would say, because red thrombus will absorb the red light. So this OCT is using infrared light, so it will absorb it, so you're not able to see this. And as you can see, it is inside the lumen, So it is likely thrombus in this case. Okay. You can crush it with a stent and treat it as such. Okay. All right, let's go to the next. So here, what can you see here? Okay. So you're seeing a stent. Okay. There's a lot of globular structure here. Okay. It's an irregular material. So this is thrombus. So this is stent thrombosis. Okay. It's inside the lumen. And if I ask you what type of thrombus it is white thrombus. Why? Because red thrombus will absorb the light and you will have shadow. Here you are not seeing any shadow. So this is white thrombus. It is more homogeneous. It has high back scatter throughout and has lower attenuation. Okay, so you'll start with probably thrombectomy if there's a lot of thrombus, clear it up and re-image and see if you can stent it if there's atherosclerosis causing this. What about this? What are you seeing here? So this is again intima, okay? And then you see a calcific nodule here. Now, as you can see, there's calcific nodule is making shadow. If it is very deep, you will not see the circumscribed area. Now, there's a deep OCT system that is going to be coming in very soon that is able to show the back end of the calcium as well. But here you are not able to see that. Again, another, calcific nodule can cause the MI and STEMI, and you can see that this is like very bright intima, which is fibrous tissue of the intima. So there's some fibrous plaque in that position. What will you do? Of course, you have to dilate this. And what will happen with dilatation? The dilatation will cause this side to dilate more. So make sure if you stent it that, you may need non-NC balloon. Okay. So, there are different people ask this question all the time from me. Should we use a compliant balloon or NC balloon? So that answer goes away when you use the imaging, because if there's calcium, use an NC balloon. If there's no calcium, use a compliant balloon. That's as simple as that. But visually, it's difficult to assess if there's a lot of calcium. So if there's a lot of calcium, I would use NC balloon. If it is not a lot of calcium, I would go with compliant balloon. Okay. All right, let's go to this one. Again, what do you see here? 5 seconds. This is calcific nodule again. However, this is not protruding. Okay. There's some small thickening in this area. Of course, you may not need to stent this, but it's visible. You can see the endothelium here, intima. You can see the external elastic lamina beautifully over here. Okay. And then adventitia behind it. Next, again, what do you see here? Another type of calcific nodule with fibrous plaque. By this time, hopefully you are able to, gather what we are doing, what we are looking at. So I'm going to get a little quicker here. All right, what do you see here? I'm going to give some time. So you're seeing some fractures in here, right? Okay. What is this? This is calcium. Seeing calcium fractures, you're seeing a dissection with a hematoma behind it. There's bleeding behind this calcium. Okay. So this is a good fracture because this is almost through the thickness of the calcium. So you can stent this. Okay. If you stent, it's properly prepped. You're going to use NC balloon if it is after the atherectomy. you're gonna get a stent size here because this side is not fully broken. So your stent is gonna expand in this direction. So you have to be careful when you're expanding that balloon. Okay. All right, so what is this? Oops. This is an interesting phenomena. Really not much literature on this, but will be great to see any comments on this. You can see some struts, and then you're seeing some tissue that is protruding inside of the stent struts. So see the stent struts here? So there's some tissue. You can have a thrombus that may be protruding inside. Okay. It can happen if there's under expansion. So you may have to post dilate with an NC balloon here to squish it back in. However, just remember this, if you're doing it in acute MI, some of this tissue may go distal and cause thrombus. So be careful about this. You can start with pre-treating the person with adenosine or maybe some antiplatelets, keep the ACT around 300, so that if that happens, you are able to take care of that. All right. So what do you think is this? Talked about this a little bit earlier. This is very bright. Okay. Very bright means this is not red thrombus. Okay. This is plaque rupture. Okay. It has some attenuation on the back, very fibrous tissue, as you can see, fibrous plaque here. This is not normal, but abnormal, but it's better than this fibrous plaque here. And, the clinical presentation will tell you if it is thrombus versus plaque rupture erosion. And this could be treated with even direct stenting because there is no calcium there. Okay. What do you think this is? Oops, that. There's a lot of blood swirl around. Okay. So this is not a great image. It is basically artifact. Okay. So what should you do? Should better engage the catheter. Okay. The catheter may not be very well engaged. If there is a stenotic lesion, the lesion is stenotic, is difficult, you can use a manual trigger. Okay. Usually many people use the automatic trigger on the OCT. You can use a manual trigger in these cases. Okay. How can you fix it? You can increase the flow rate of the contrast. Okay. So if you have the assist system, you can increase the flow rate on that. Usually people use 4 for 14 ml. Okay, that's the usual assist rate. You can increase it to 6 or 8. Okay, just to clear it quickly. And if it is a proximal issue, then you have to increase the volume. Okay, if it's proximal, like if it's a distal issue, then you need to increase the rate. If it's a because so the contrast can reach there quickly. If there's a proximal issue, you have to increase the volume because that means the vessel is not clearing up. With manifold, it's very difficult. Many manifolds are not more than 10 ml. You can have 20 ml syringes. However, you need a lot of force to push through. But if you have a smaller amount of volume, you can push harder, of course, and the rate will go up. And that so for distal, push it quicker. For the proximal, use a larger syringe. And with assist, it's easy. You can even go up to 20 ml here. Okay, with assist system. All right, this is again another one. Show and tell. What do you think? Normal vessel, almost normal vessel. Okay. And then you have fibrous plaque here developing, and there's lipid developing here. Okay, so that's what it is. Now, this is a high amount of lipid. If you're putting a stent, do not put the stent edge on this, even though the lumen looks awesome. Why? Because this will rupture and you will have either plaque shift, or you may end up causing distal embolization and no reflow. So that's the benefit of looking at this OCT. Okay, what do you think this is? Now this is, again, a lot of fibrous plaque. Okay. This area, as you can see, has high attenuation. This is lipid 4. And again, you don't want to stent into this thing, especially because you see this intima has got what? Very thinned out, called TICFA, thin cap fibroatheromatous plaque. High risk of stent edge dissection. So do not stent and end your stent in this area. Okay. Right. We'll do the next part 2 after this. Okay. Hello.